Thank you, Kirtida, and thanks the chairperson for an really wonderful introduction of mine. A warm hello to all the friends who have joined on this Sunday leisurely afternoon, and I must really thank them for sparing the time. At the onset, I congratulate Endocrine Society of India for this wonderful weekly seminars which they are organizing, and that is really helping us to connect with each other. I also would like to thank the organizers for giving me an excellent opportunity to talk on the topic like endocrine myopathy. A special thank to Dr. Shaila and Dr. Saptarshi for choosing me to deliver on this topic of endocrine myopathy. When Dr. Shaila actually gave me that I have to talk on endocrine myopathy, I was really very happy uh, because when I was talking with the fellow neurophysician as to I have been asked to talk on endocrine myopathies, and we were just discussing uh, that majority of neurology problems are really chronic problems which are not reversible and which go on for quite long. As opposed to that, all the endocrine problems are quite reversible, and majority of them are quite you can say curable. uh, I would always say that endocrinology is an happy branch of medicine. It is an happy crinology. And we always fighted amongst us saying that no, neurology is something which, keeps the quality of life really down. And this goes on. And to share a small secret, that neurophysician is my husband, so you know who is going to win the quarrel. Jokes apart, I would just like to say that whenever a clinician deals with a myopathy or a skeletal disease, he really wants to know whether this myopathy is reversible, whether I can cure this myopathy, and hence there is always a search for reversible causes of myopathy, and endocrine myopathy is one of that. Endocrine myopathy is basically when the structure of muscle is normal but function suffers because either there is deficiency or there is excess of hormone. Myopathy presentation is usually a small part of whole say endocrine syndrome, and rarely myopathy will precede the manifestations of endocrine syndrome. Once the hormone is corrected, the myopathy reverses back because muscle basically is normal. So for diagnosis of endocrine myopathy, only tool which I would say you need is a very good clinical acumen, and you rarely need uh, mm, say advanced investigations like EMG, nerve conduction, or muscle biopsy. Those are needed, but very, very rarely. Whenever a myopathy presents, usually if it presents with a clinical picture like this, a very frank picture of thyrotoxicosis. So myopathy takes a backseat because the clinician would be really focusing on the thyrotoxicosis syndrome and its treatment. As compared to that, this girl who presented with a very subtle signs of irregular menstrual periods, weight gain, and started having little bit of acanthosis. She was initially treated with irregular periods like any polycystic ovarian syndrome patient, but later she developed proximal vessel weakness, and that time the suspicion aroused that whether she is suffering from any other hormonal disease. She was then investigated and was found to have Cushing's disease and had microadenoma, which was cured after surgery. So every time the degree of clue to the etiology given by the underlying endocrine myopathy may be variable, and sometimes you may not get any clinical clue but you have to use your clinical acumen and suspect an endocrine pathology. Like sometimes a patient with hypertension can present with hypokalemic periodic paralysis. You happen to do ultrasonography and you find an adrenal adenoma. So that can be a primary hyperaldosteronism in a plain patient of hypertension who had hypokalemia and who presented with hypokalemic periodic paralysis. So the clinical features of underlying endocrine disorder may be variable. These are all the glands which I'm going to discuss. When we know that either deficiency or excess of all these hormones can cause endocrine myopathy. But I also thought that I would like to deal with just few slides on two drugs which we commonly use, and those are steroids and statins, because those are also known to affect the muscles. So let us come to the first gland, that is thyroid related myopathy. Thyroid, as you can see, either in deficiency or in excess, both can affect the muscle. The hypothyroidism basically can affect muscle, or we know as majority of our hypothyroid patients are suffering from autoimmune hypothyroidism. So there is always an associated polyautoimmunity along with hypothyroidism. So either hypothyroidism itself or associated autoimmune issues can cause myopathy, and hence you need to be aware of these associations as well. Thyrotoxicosis typically causes these four kind of myopathies, where chronic myopathy is a part of a big thyrotoxic syndrome, Graves' ophthalmopathy, hypokalemic periodic paralysis, and an association of myasthenia gravis. We all know that hypothyroidism clinical manifestations will really vary as to when it occurs. So, if it occurs in the childhood or in the congenital age group, the manifestations would be really different as compared to adult hypothyroidism. Now, as you can see in this child who presented at the age of 10 years with menorrhagia, and to the extent that it led to severe anemia. Clinically, she was frankly hypothyroid, but she was undiagnosed for long time. It's a very unfortunate that she was not diagnosed, because you can see she had very frank hypothyroid signs. As you can see, her leg muscles, she had muscular hypertrophy, but those were actually weak muscles. And this is what we called as Cocker-Debris syndrome. This is a long-standing moderate to severe hypothyroidism in pediatric age group. And if it is not seen in a full clinical context, then it may be confused with the primary muscle disorder. It's always a rewarding diagnosis, I would say, whenever you diagnose juvenile hypothyroidism or congenital hypothyroidism for that matter, because these patients, once you treat them adequately, the recovery is dramatic, and it makes worthwhile contribution to the life of that person, because it transforms uh, the treatment transforms the life of person completely. Now, in adult hypothyroidism, we are really, with widespread use of thyroid function test, availability of thyroid function test in outpatient departments, we are always encountered with patients who are testing thyroid for any slight muscle pain or any slight body ache. And many times they come with the report to you saying that I tested thyroid because I had muscle pain, body pain, and all. And almost 80% of diagnosed hypothyroid patients really do have weakness, fatigue, muscle cramps, or stiffness. The slow relaxation of deep tendon reflexes is commonly seen as we elicit in supinator jerks. And although percussion myodema described, it is really rarely seen. And if you get a pseudohypertrophy of muscles in adults, then that we called is at an Hoffman syndrome. Very rarely, hypothyroidism can manifest with rhabdomyolysis, and sometimes associated small fiber distal peripheral neuropathy may be present, and it can really confuse the pictures. Serum creatinine kinase is elevated sometimes, and it definitely normalizes with thyroxine replacement. This was a routine hypothyroid patient. See, in OPD, many times, especially when the female patient is there, they always complain of body ache, body pain, idhar dukta hai, udhar dukta hai, and we are all used to those kind of complaints, and we tend to neglect those complaints many times. This was a lady who was frankly hypothyroid who presented to me with hypothyroidism of duration of 1 year. She was well controlled on thyroxine 100 micrograms per day, and even after 6 months, when her TSH normalized, she had persistent body pain, muscle ache, pain in her joints. Uh, Joint pain had decreased, but she had myalgia. Vitamin D, calcium, B12, and hemoglobin status, they were all checked and they were found to be normal. She followed up after 6 months saying that she had difficulty in climbing stairs and she has difficulty in, getting up from squatting position. This is the time when I realized that she's suffering from proximal myopathy, and a neurophysician's opinion was taken. She also had developed a heliotropic rash on the face, and she was diagnosed with further investigations with muscle biopsy and all the added investigations as a case of dermatomyositis. So I just want to emphasize one point that from this case, that her plain simple hypothyroidism led her to an involvement in the other systems which were treated with steroids, azathioprine, and all the other agents. And she gradually recovered. Her steroids were tapered, and she gradually recovered. But this polyautoimmunity in hypothyroid patients must be kept in mind, especially when the symptoms are persistent, or a new or a specific group of muscle gets involved. Then you need to be very careful in analyzing whether this patient is suffering from any associated either rheumatological or neurological problem. This associated autoimmunity then really changes your priorities in treatment, and a simple hypothyroid patient then has a lot of other drugs, and then thyroxine becomes a minuscule but an important part in treatment of our disease. So I would just like to say that clinical medicine is a great teacher, and you never stop learning when you are treating patients. This was another patient, the person with the pink sari. She was referred from an interior village, and the referring clinician told me, Madam, this patient has all the signs and symptoms of hypothyroidism, but her TSH is normal. Can you please see what is going on? And when she came, she had this severe sallow picture, anemia, extreme muscle weakness, asthenia, loss of appetite. And when I saw this thyroid function test, I realized that her T3 was low, T4 was low, and TSH was also low. So this was nothing but secondary hypothyroidism, which was due to some pituitary cause. She didn't have any visual complaints, but on further evaluation, she was found to have an empty sella syndrome. So, a pituitary cause of hypothyroidism, if the tumor is hypersecreting, like in this patient with acromegaly, then the diagnosis is quite early. But if the tumor is non-secreting and it is not compressing the optic tracts, then the diagnosis may be delayed. And you can directly have a patient with empty sella syndrome and multiple hormonal deficiencies. So cortisol deficiency really added to the generalized weakness. The patient on the left was treated with prednisolone and thyroxine, and she improved. The patient with acromegaly was operated, and post-operatively, she again had hypothyroid and hypocortisolism, which was corrected. So one thing which I really want to stress is normal TSH does not rule out hypothyroidism, and you just need to uh, check the whole thyroid profile and the whole clinical picture. This was about hypothyroidism. Now I would come towards the hypersecretion of thyroid gland, and these are the four typical muscle involvement which we see in a thyrotoxicosis. This is a progressive, like in chronic thyrotoxic or Graves person, you can have a progressive muscle weakness in the form of weight loss, palpitation, tremors, and there is a lot of muscle wasting also as a part of, you can say, catabolic state of thyrotoxicosis. Majority of patients will have this kind of weakness, and the proximal muscle weakness is more common, especially at the hip muscles, and only 20% will have distal myopathy. Bulbar or respiratory muscle involvement is not seen. The deep tendon reflexes are brisk and serum kinase would be normal. And all these weakness again will recover fully once you treat that thyrotoxicosis. So again, when you are treating a patient of thyrotoxicosis, what you assure the patient is that once I treat your thyrotoxicosis, all your muscle problems are going to be solved. Another very commonly seen along with Graves is this Graves ophthalmopathy, where you have infiltration of orbital muscles because of cross autoimmunity. And inferior rectus and medial rectus are the muscles which are commonly involved. Now, when this Graves ophthalmopathy occurs along with the thyrotoxicosis pictures, then it is very easy to diagnose because it is a part of complete picture. But sometimes this ophthalmopathy may precede or follow the onset of hyperthyroidism. Like in the patient shown below, she developed thyrotoxic ophthalmopathy after her phase of thyrotoxicosis was over. So sometimes it can be little tricky, but if you take proper history and proper examination, you are supposed you will be able to diagnose. These patients need additional steroids, but they do recover with little bit of remnant proptosis. Sometimes in patients with thyrotoxicosis, like this patient, the hypokalemic periodic paralysis led to the diagnosis of Graves' disease. He was a 45-year male who presented almost 3 times with hypokalemic periodic paralysis. His 2 episodes were treated locally without much documentation, and third time when he came to our hospital, he had low potassium on investigations. His periodic paralysis improved dramatically with potassium correction. He didn't have goiter, but there was mild redness and proptosis, and that is how his thyrotoxicosis was picked up. After treatment of his thyrotoxicosis, his episodes of hypokalemic periodic paralysis totally vanished. So this thyrotoxic hypokalemic periodic paralysis is again a peculiar entity of Asian males, where there is episodic proximal more than distal or generalized flaccid paralysis with hyporeflexia, which is precipitated by high carbohydrate content or say alcohol intake. And it is majority of times associated with hypokalemia, but sometimes even normo or hyperkalemic paralysis can be seen. So whenever a patient presents with repeated episodes of hypokalemic periodic paralysis, even if patient doesn't have ophthalmopathy or goiter, it is worthwhile doing his thyroid function test to rule out thyrotoxicosis, especially because once you treat that thyrotoxicosis, patient is cured of his periodic paralysis. This is another peculiar association of myasthenia along with hyperthyroidism, and you should suspect myasthenia in patient with thyrotoxicosis, especially if the cranial or bulbar muscles get involved, because those are rarely involved in a plain simple Graves disease. In Graves, we have proptosis, but if your patient has ptosis or muscular weakness, then you should suspect myasthenia. Any patient who needs ventilatory support, but it's very difficult to wean off that ventilatory support, then myasthenia must be ruled out. Either of these conditions may come together or they may precede each other. So it's always better to keep it at the back of mind that they may be associated with each other. That was about thyroid causing myopathy. Now we come to another important endocrine gland, and that is adrenal gland. Now, steroid excess and deficiency both can cause myopathy. And the steroid excess can be because of endogenous overproduction, either from the pituitary, adrenal, or ectopic source, or it can be because of iatrogenic steroid ingestion. Steroid basically causes inhibition of protein synthesis with increased catabolic state. It also alters some muscle growth factors, and of course hypokalemia. These are the 3 or 4 factors which are responsible for the involvement of muscle with steroids. We are all aware of Harvey Cushing's, a great man who described all the features of endogenous hypercortisolemia, where because of excessive cortisol production, whatever may be the source of cortisol production, there is slow onset progressive weakness in the muscles, which are mainly observed in the lower limbs. There is a lot of muscle wasting, and you can have very thin limbs and abdominal fat, or what we called as a lemon on stick appearance. Sometimes that Cushing's developed so rapidly, especially in some cases of ectopic Cushing's, that hypercortisolemia, which is developing very, very rapidly, doesn't give any time for body for muscle wasting or weakness. But these patients usually have severe hypokalemia, and that leads to profound muscular weakness. Bulbar involvement is not seen, and respiratory muscle in weakness, it can be very severe, and it can get worse, especially when hypokalemia is not corrected adequately preoperatively. Again, this hypercortisolism can have a wide spectrum of presentation. Like in this girl, the spectrum, the severity of hypercortisolemia was not very severe, I would say, and she was a very well preserved girl who was diagnosed early and cured early. So she only presented with a proximal myopathy, which was cured after her surgery was done. As opposed to that, this lady who had a severe generalized weakness, very high and long say course of exposure to the hypercortisolism, she had proximal myopathy at hip and shoulder. Her hypokalemia was very difficult to correct. Metabolic acidosis also once worsened her weakness, and postoperatively she had a very stormy course because of those respiratory muscle involvement. So the spectrum of hypercortisolism involving the muscle would depend on the degree of hypercortisolism and the duration or the years for which the patient has been exposed to those high levels of cortisol. This was a typical case of exogenous steroid myopathy. He was a man who was taking some Ayurvedic medicine which may be contaminated with steroids for almost 2-3 years, and landed up with exogenous steroids or exogenous Cushing's. I think this is the commonest drug-induced myopathy, especially in India, where we have a lot of indigenous preparations which are given in the name of there are no side effects of those. They have slow onset progression. Usually they have painless pelvic girdle myopathy. Cranial nerve involvement or sphincters are spared. And this long-term use can lead to really wasting and atrophy of the muscles. This patient had really long course when it was tried to wean him of steroids. Who are the patients who are more prone for steroid myopathy? Elderly patients who are longly inactive for more time, sensitizes their muscles to catabolic steroids. Or some patients where there is systemic malignancy, the respiratory muscles may be involved. Use of fluorinated steroids like betamethasone or triamcinolone or dexamethasone, they can really cause exogenous Cushing's. Use of steroids in the range of say 40 to 60 milligram can cause exogenous Cushing's even in 2 to 3 weeks time, and weakness recovers after withdrawing the steroids. Of course, while withdrawing, you have to shift them to non-fluorinated steroids so that they don't suffer from any adrenal deficiency symptoms. Sometimes for inflammatory myopathies, patients are being put on steroids, high dose steroids, and there is always a diagnostic dilemma that when the muscle weakness increases, is it because of the steroid induced myopathy or is it because of underlying inflammatory myopathy? And the answer usually is when the CPK is raised, it is usually because of inflammatory myopathy. And if it is because of steroids, once you reduce the doses, the weakness reduces little bit. So it's always a diagnostic dilemma when you are treating them on steroids. As compared to the chronic steroid, exogenous steroid myopathy, the acute steroid or what we call as critical care myopathy is really a poorly understood entity, I would say. It occurs in chronically or critically ill patients who are mechanically ventilated and who receive long, high doses of steroids. And they present with acute onset proximal plus distal muscle weakness. And predisposing factors, of course, are patients who have coexisting sepsis, nutritional deficiencies, who are prolongedly immobile, or some neuromuscular blocking agents are used. And weaning of these patients off mechanical ventilation becomes a real big task because it is very poor. Their weaning is very difficult, and it extends their ICU stay. Stopping steroids is the only solution, but it takes long time for steroids to be tapered off without any event, and CPK may be raised in these conditions. So this is actually a poorly understood, I would say, acute steroid or critical care illness, myopathy, related with steroids. Adrenal insufficiency, as I said, cortisol excess, same way, cortisol deficiency also leads to muscle weakness. But majority of times, this muscle weakness is generalized weakness, fatigue, muscle cramp, which really improve dramatically after glucocorticoid replacements. And it is majority of time because of water or electrolyte imbalance rather than the muscle problem. Like this girl who started with candidiasis, hypoparathyroidism, and then developed adrenal insufficiency as a part of her polyglandular autoimmune failure, and she recovered well after steroid supplementation. So again, a poly autoimmunity must be kept in mind in all endocrine disorders, either involving the other gland or involving other systems. Primary hyperaldosteronism again can cause myopathy majority of times because of existing hypokalemia. Another important gland which I would say governs the muscle health or muscle, I can say, status, and that is calcium and phosphorus governing gland, that is parathyroid gland. Its hypersecretion, that is hyperparathyroidism, can cause hypercalcemia. It can lead to non-necrotizing illness, or hypophosphatemia can lead to sometimes necrotizing myopathy and very rarely rhabdomyolysis. Hyperparathyroidism, as described by Hirschberg in 1889, had described a myopathy which was present, we know, in almost all hyperparathyroid patients. 80-90% of them will have diffuse bony pain, diffuse muscle pain, proximal muscle weakness, and their fractures, they really have difficulty in walking and they can have a waddling gait. And associated vitamin D deficiency, which is very common in Indian patients, can really worsen the pictures. And surgical removal and normalization of calcium and phosphorus uh, over a time gradually improves this myopathy. It's not only calcium, but phosphorus also is extremely important for maintaining a normal muscle and bone health. And I would just like to share with you a story of a 33-year male who was medical representative by profession. He presented to me with diffuse pain, muscle weakness since 2 years. Gradually, his pain and aches increased. He was not able to climb stairs, gradually, not able to even move around in the house. He was homebound. He was ultimately bedridden. And he found it extremely difficult even to turn in bed with severe muscle weakness. So one day, while turning in bed with some pressure on the right radius, he had fractured that right radius. He was seen by a rheumatologist who did bone scan and found that he had multiple fractures, including rib, pelvic rami, and right radius, which was very obvious. He was literally carried in a lab by two people to my OPD. And as you can see, these were his fractures on the right hand. And if you can see his biochemistry, his calcium is normal, his PTH is normal, his vitamin D was normal. So this was non-PTH dependent normocalcemic, I would say, a disease where alkaline phosphatase was definitely elevated. And if you can carefully see, his phosphorus was low. I would like to thank whole KM department for helping me in managing this patient. This patient was referred there. Gallium DOTA scan was done, and as you can see here in the right femur upper end, a tumor was localized, which was excised. That is the excised sample, and you can see post-operatively his phosphorus normalized. His FGF 23 levels, which were sky high pre-operatively, in the range of thousands, came back post-operatively normal. And this is there is almost 1.5 years now since his surgery, and now he can really climb up stairs and come to my OPD for follow. So this was a remarkable recovery because of tumor-induced hypophosphatemic osteomalacia. Because the tumor was localized and operated successfully, that person is now able to walk. Hypophosphatemic osteomalacia and myopathy, as I said, is characterized by phosphate wasting, and it's usually secreted by small, usually benign mesenchymal tumors, which are very difficult to localize. And once you operate, the patient is totally cured. Vitamin D deficiency, what should I say? With the greater availability of vitamin D assays, and everyone doing their vitamin D levels left, right, and centers, we are having so many patients with vitamin D deficiency. Whatever may be the reason why they are suffering from vitamin D deficiency, but so many people are deficient, so many people are being supplemented. But I would just like to share a story of this 50-year male patient who worked as in a private bank as a cashier, and his section was situated in the basement. He used to travel to bank in AC car. His whole day would go in that basement wala office, and he would return home at around 8 o'clock in the at night. Gradually he started having pain in muscles, pain in bones, and he had difficulty in climbing the stairs, and his vitamin D was 5.6 nanogram per ml. So a person who is so well off, a person who is so having good nutrition, everything was really well, but suffered from vitamin D deficiency because there was no sun exposure at all. Maybe we can call it as an five star osteomalacia, which is uh, deficiency in all the plenties. Vitamin D is extremely important for prevention of fall. We all know that in when we are treating patients with osteoporosis, vitamin D deficiency can lead to weakness in gluteus and hamstrings, and increases tendency to fall. So if you supplement it, then you can really prevent the falls. Pituitary, again, that was up to vitamin D. Then a very passing remark about acromegaly, that pituitary can cause myopathy with all the secretory tumors, and if you treat them, it really cures. It is cured. Last few slides about a drug causing which we are using routinely. Uh, I would say that myopathy described with statins is a overrated side effect, but which is really rarely seen. And we are using statins quite a lot. There's a wide spectrum of clinical presentation, ranging from asymptomatic hypersicemia to myalgia, cramps, myopathy, myositis, myonecrosis, and very rarely rhabdomyolysis, leading to myonecrosis and myoglobinuria. At risk individuals would be people who are vitamin D deficient, hypothyroids, renal disease, liver disease, or their concurrent use of drugs like fenofibrate, amiodarone, calcium channel blockers, niacin, and all. And there are some genes which are being isolated and which are being associated with increased propensity towards statin myopathy. Although this is described, a routine creatinine kinase monitoring is not recommended. Although many books says that basal CK need to be done before you start statin. No other treatment is usually required except cessation of statin. Once you correct the vitamin D and TSH status, maybe myalgia and mild muscle pain goes away. You can reduce the dose, give half dose, make the alternate day dose, and usually that subsides. If at all, if it is not subsiding, then you can switch to other statins like pravastatin, fluvastatin, or pitavastatins. And special care, of course, need to be taken in if the patient develops rhabdomyolysis or immune mediated necrotizing myopathy. So, in summary, I would like to say that many times endocrine myopathy presents as a part of syndrome of either excess or deficiency of hormone. Very rarely, myopathy will lead to diagnosis of endocrine disease because the structurally muscle is normal, creatinine kinase is normal, and all recover well after treating the underlying cause of that myopathy. And hence, I would like to reiterate again that endocrinology is happy crinology, and so it's a great happy branch of medicine to practice, and it really gives you great results. Thank you very much for patient hearing.